You guys ready? Excited to learn everything it is to know about allergy and immunology? Yeah? All right, let's go. Right, buckle up. We got a lot of slides to cover, a lot of information to cover, so hold on tight. Okay. So why is allergy and immunology really important? Well, if you look at the American Board of Pediatrics content specifications, about 3.5% of all the questions are going to be from allergy and immunology. Well, that may not sound like a lot, but if you look at some of the other topics and subjects like GI or endocrinology, it ranks pretty high up there in terms of the percent of questions that belong to allergy and immunology. And so that's far more than cardiology or renal, but of course the highest one is growth and development. Okay. So what we're going to do today is we're going to go over the immune system. And I think some of the questions that you guys will have in terms of the boards is that they're going to give you a clinical vignette with a child with recurrent infections. And then they'll give you some information as to what kind of infection it is, and you have to work your way backwards to figure out what kind of diagnosis does the child have. Or they may even be even trickier, and they may ask you what are some of the complications or what are some tests that you need to order in order to make the diagnosis. So in order to do that, we need to have an understanding of the immune system, at least a fundamental and basic understanding of the immune system. So I'm going to go over the immune system. We're going to first look at the innate versus the adaptive immune system. We'll also talk about some of the players of the immune system, including T cells, B cells, complement, and antibodies. And then we'll go over some of the specific primary immunodeficiencies that they're likely going to ask you about in your boards. After that, we'll talk about some hypersensitivity reactions, and then we'll talk about next allergic disorders such as anaphylaxis, urticaria, asthma, allergic rhinitis. I won't spend too much time about asthma because I think in the pulmonary section they spend a lot of time with asthma. And then we'll also touch up on some other immunological disorders such as serum sickness and also mastocytosis. Okay. All right. So the immune system. So classically, the immune system has been kind of divided into the innate immune system and the adaptive immune system. The innate immune system is very rapidly acting. It's nonspecific, however, and it doesn't have any memory. So some of the most important players in the innate immune system include complement, macrophages, and natural killer cells. The adaptive immune system, however, is much slower to respond, but it's very, very specific, and it also is able to induce memory. So the adaptive immune system is also subdivided into the humoral subset, which include B cells, plasma cells, and immunoglobulins. And then you also have the cell-mediated portion, which includes T cells, activated macrophages, and activated natural killer cells. So what's the difference between the innate versus the adaptive immune system? Well, the difference really is from their receptors. So for example, the innate immune system receptors are generic, ready-made receptors. An example of this is a toll-like receptor. This allows for quick but non-specific responses. These toll-like receptors, for example, can recognize certain patterns on pathogens. For example, toll-like receptor 4 can recognize LPS on gram-negative bacteria, so it can tell the innate immune system that it's being under attack by gram-negative bacteria. The adaptive immune system, however, has custom-made receptors. These are found on your T cells and on your B cells. So these receptors are very refined, they're very specific, and they recognize an infinite variety of pathogens. So that's amazing if you think about it, that by the time you're born, you're able to develop an infinite response to any pathogen that's out there. Now, although we usually divide the innate and adaptive immune system, there's a lot of overlap, and there's a lot of communication that goes along between the innate immune system and the adaptive immune system. So the innate immune system sort of serve as the first responders in an attack. They recognize microbial structures that are common to many members of a group of pathogens. Going back to that example that I talked to you about before, the toll-like receptor 4, which recognizes LPS and gram-negative bacteria. So with this, the innate immune system is able to provide signals to the adaptive immune system in order for the adaptive immune system to then respond. So as an example, macrophages which are part of the innate immune system, can engulf bacteria and then can provide signals to T cells, which are part of the adaptive immune system. Now there's a lot of overlap as well too. Some cells, such as macrophages and natural killer cells, initially function as part of the innate immune system. However, they can be activated later on by T cells and act part of the adaptive immune system as well. Now, to complicate things even further, there are some things called innate-like cells. These cells are part of the adaptive immune system, but they're sort of like hybrid cells, so they're more rapid-acting and they're less specific. So examples of these include your delta gamma cells, which are found in your gut primarily, also natural killer T cells, B1 cells, which are sort of like innate-like versions of your regular conventional B cells, and these are found in your pleural space and also your peritoneum. And then you've got marginal B cells, which are found in your spleen. These act sort of like innate immune cells because they're much quicker to respond, but they're less specific. Okay. So in terms of the players, we have your lymphoid cells, which include your lymphocytes, your B cells, the B1, B2, and conventional cells, which I just mentioned. Your T cells, which include the typical T cells that we think about, the alpha-beta T cells, which include your CD8 cytotoxic T cells, CD4 helper cells. You've got your delta gamma T cells, which are your innate-like cells, and you got your natural killer T cells and your natural killer cells, which I'll go in further detail in a little bit. And then you've got your myeloid system, which cells which include your granulocytes, neutrophils, eosinophils, mast cells, so on and so on. And so if you kind of look here, you've got your lymphoid cells and your myeloid cells, and the granulocytes are part of your innate immune system, which also includes dendritic cells, macrophages, and natural killer cells. And then you've got your adaptive cells, which include B cells and T cells. And then you've got your sort of hybrid cells, these innate-like cells. So let's just take a step back and sort of review the nomenclature, because I know sometimes it gets really, really confusing, especially when we talk about CD this, CD that. It all kind of sounds like alphabet soup, basically. So what CD stand for? They stand for clusters of differentiation. So basically, what you should think about them is they're like name tags on immune cells. They allow us to recognize what type of cells they are. So for example, if we're talking about a helper T cell, we talk about CD4, for example. If we're talking about a cytotoxic T cell, we talk about CD8, for example. Okay? Now, what are interleukins? Okay? Interleukins are the language of immune cells. They basically are secreted by one cell to tell another cell what to do. So for example, if a cell produces a lot of interferon gamma or IL-12, it tells another cells that we're being under attack by most likely microbial organisms or tuberculosis or whatnot. Okay? So these are kind of like the language, the immune speak of immunology. So the whole paradigm of immunology rests upon the major histocompatibility complex, or in humans, HLA, or human leukocyte antigen. What the MHC does is it allows the body to recognize self from non-self material. Okay? And these MHCs, or HLAs, are encoded on chromosome 6. There's 3 classes of HLA antigens, class 1, class 2, and class 3. So for class 1, these are found in almost every single cell except for mature red blood cells or non-nucleated cells. And so these classes basically tell the immune system, hey, this is self. This is something that's part of our cells. And so cytotoxic T cells can only recognize antigen when they're presented in the context of a class 1 MHC or HLA molecule. So in any cell, the cell presents antigen, its own antigen, endogenous antigen, in the context of an MHC1 molecule. So when a cytotoxic T cell comes along with its T cell receptor, it can only recognize that antigen when it's presented in the context of that MHC1 molecule. Now, class 2 MHC or HLA are only found in antigen-presenting cells. So what are these? These are monocytes, these are macrophages, these are dendritic cells, Langerhans cells, and sometimes B cells can also act as antigen-presenting cells. So helper T cells, or CD4 positive T cells, can only recognize antigen when they're presented in the context of an MHC2 molecule. Okay. So here, as an example, we have a macrophage. It's engulfed some type of antigen, and now it's presenting that antigen in the context of an MHC2 molecule. And so this helper T cell comes along with its T cell receptor, and it has to recognize both the antigen and the MHC2 molecule. As you can see here, this interaction is stabilized by the CD4 receptor. Okay. So what is this concept of HLA restriction? Well, as I just mentioned, CD8 T cells can only recognize antigen when it's presented in the context of a class 1 MHC molecule, and CD4 T cells can only recognize antigen when it's presented in the context of a class 2 antigen. So a nice way to remember this is 8 times 1 is 8, and 4 times 2 is 8, and 8 is great. Okay. All right, so now let's talk about the different arms of the immune system. We'll first talk about T cells, okay, and go over T cells. So what's the function of a T cell? Well, T cells are important for destroying intracellular organisms, and they also regulate antibody production by B cells. So the T cell receptor, kind of like the B cell receptor, can recognize an almost infinite variety of protein antigens when presented in the context of an MHC molecule. This T cell receptor is always associated with something called CD3, which is required for signal transduction for the T cell. So all T cells will have this CD3 on their cell surface. Now, going over the different subsets, there's helper T cells like CD4 T cells, and these are important for defense against extracellular pathogens. And they're divided in Th1 subsets and Th2 subsets. The Th1 subsets induce cytotoxic T cells or CD8 positive cells and lead to cell-mediated immunity, whereas Th2 subsets induce B cells to produce antibodies and also induce humoral immunity. Now, CD8 or cytotoxic T cells, as the name implies, are important for defense against intracellular pathogens and also tumor surveillance. Okay. Now, there's something called natural killer T cells. Now, I'll sort of explain the name. So these natural killer T cells recognize lipids and glycoproteins in the context of an MHC molecule, something called CD1. And that's why they're called T cells, because remember, T cells can only recognize proteins, or in this case, lipids, in the context of an MHC molecule. Now, why are they called natural killer T cells? Well, they're natural killer T cells because they also share that CD16 and CD56 name tag, which is found on natural killer cells. And so these cells are kind of innate, they're kind of like hybrid cells. And just remember, these are different than your natural killer cells. They're natural killer T cells. There's also something called T regulatory cells. These, the expression of these cells are controlled by a transcription factor called FOXP3, which controls their development and function. And their function is to suppress or regulate the immune system. And they do this by secreting suppressive cytokines like IL-10 and TGF-beta. Natural killer cells are important for innate immune responses to tumors and viruses. Like I mentioned before, they express CD16 and CD56. And so why are these natural killer cells important? Well, remember, some viruses are able to reduce MHC expression, protecting them from recognition by cytotoxic T cells. This, viruses can invade the cell, and remember, cytotoxic T cells have to recognize antigen, and they have to recognize it in the context of an MHC molecule. Now, viruses have gotten really smart. What they do is they suppress the expression of this MHC1 molecule. So if you don't express MHC1, basically the cytotoxic T cell can't recognize that that cell has been invaded by viruses. With natural killer cells, these cells are always in a kill mode. So they will kill that cell unless it recognizes something called HLA-E on the target cell. Okay, so it's kind of a way where viruses have evolved to evade the host immune system, and then the host immune system has found another way to sort of counteract the virus. Okay. Now let's move on to B cells. B cells have essentially two functions. One, they produce antibodies, and two, as I mentioned before, they can act as antigen-presenting cells by presenting foreign protein antigens to T cells. Okay. So antibodies, first of all, are composed of two heavy chains and two light chains. There's 5 isotypes, as you all know. IgM, IgD, IgG, IgE, and IgA, and they function in 3 different ways. One is opsonization, meaning that they can coat the foreign pathogen and surround it, and this targets it for destruction. Secondly, they can neutralize certain viruses or toxins. And then finally, they're important for complement activation. So they essentially have 3 separate functions. And as you can see here, this here is a antibody structure. You've got your heavy chain here, okay, in blue, and then you've got your light chain in yellow, okay. The Fab region is the region that where the antibody binds to certain pathogens or toxins, and the FC portion is the effector portion. It's what basically determines the function of that antibody. Okay. So let's start off with the different classes of antibody. IgG is the main antibody in serum. It's the major antibody in immune responses, and there's 4 subclasses, IgG1, 2, 3, and 4. It readily crosses the placenta, so that's why the maternal antibodies protect the infant until 4 to 6 months of age. Actually, in the 3rd trimester, you have an actual active pumping of maternal antibodies, IgG, into the baby. And so when the baby is born, its IgG levels are actually higher than the mom's IgG level. And so why do babies start getting infections at 4 to 6 months? Well, it turns out that there's turnover of IgG. The half-life of IgG is about 21 days. So you think about, how long it takes to clear antibody. It takes about 4 or 5 half-lives to clear, and that turns out to be about 4 to 6 months. So that's why babies start developing ear infections at about 4 to 6 months. Okay? So immunology is very, very simple. It's very, very simple. Trust me. Okay? All right. IgD can also activate complement. Okay? All right. Now, IgM is the first Ig class produced in an infection. So it's helpful for us because we can diagnose recent infections. All right? We can get titers, IgM versus IgG titers, to determine if it's an acute versus chronic infection. IgM is the best antibody for complement activation. Why is that? Well, it's because it's secreted as a pentamer. Well, there's 5 of them, all put together. So if you got 5 of them, it's more likely to activate complement. Again, see how simple it is? Okay. Okay. All right, IgA. Now, IgA is the main antibody in secretions, and it's important for mucosal defense. All right, it's secreted as a dimer. There are 2 immunoglobulins attached with a J chain and a secretory component, which is derived from the epithelial or liver cell receptor. And it's the main antibody found in breast milk, okay? And it does not activate complement. Well, do you guys know why moms kiss their babies, or why, dogs lick their babies? They're surveying the flora, the microbial organisms. So when the mom, kisses their baby, they're surveying the pathogens on the baby, and then they produce IgA antibodies that's produced in breast milk. There you go. See, very simple, right? Now, IgA does not activate complement. Why is that? All right? Why is that? Why would you not want to have IgA start activating complement? Well, think about where it's at. It's in the gut. It's in the mucosa. What are you constantly introducing every single day that's foreign? You're introducing food. You're eating new things. So it would be horrible to have complement activating in your gut. It would be absolutely terrible, right? So IgA is secreted as a dimer. There's 2 immunoglobulins attached together through a J chain. And as I mentioned before, IgA is found in secretions and also in breast milk. All right. Now, IgE is the bane of allergist's existence. It is the bane, but it keeps us in business, so I guess it's okay. All right, it's the lowest concentration normal serum, and it's involved in allergic reactions and also parasitic infections. All right. So what happens? You got your mast cell. There's Ig receptors on the mast cells. The Ig binds to allergen. It cross-links. It causes all these mast cells to release all of its products, and you have, lo and behold, an allergic reaction. Okay. So we're going to really just touch upon complement pathways. There's 3 pathways: the classical pathway, the mannose binding pathway, and the alternative pathway. All right. Now, I won't go over this in any too much detail. Just know that they all kind of converge into one area, and they all produce the MAC, or membrane attack complex, which is able to poke holes in bacterial cell walls. It also releases a lot of byproducts, such as C3b, which is important for opsonization, and C5a, which is important for inflammation, and also can act as an anaphylatoxin. All right, so with that sort of basic knowledge about immunology, let's move on to actually primary immunodeficiencies. There's over 150 primary immunodeficiencies, and of course I'm not able to go over every single one of them, but I'm going to go over the main ones that they're most likely to ask you about on your boards. Okay. All right. So in order to sort of, get the question correct or think about immunodeficiency, you want to think about which arm of the immune system is defective, and which arm of the immune system is responsible for each particular pathogen. Right? So let's take a step back and look at T-cell deficiency. Right? So T-cells, as I mentioned before, are important for defense against intracellular organisms and against opportunistic infections. So what are patients with T-cell defects going to get? So they're going to get bacterial infections with Salmonella, syphilis, mycobacteria such as MTB, MAC, MAI. They're going to get infections with viruses, again intracellular, most commonly within the herpes family of viruses such as CMV, HSV, varicella, EBV. They're going to get fungal infections with Candida, Aspergillus, Cryptococcus, Histo, Cocci, and they're going to get protozoan infections such as PJP, or formerly known as PCP, Toxo, Isosporidius, and Microsporidosis. And so if you think about, what these infections are commonly attributed to, it's HIV, right? HIV patients, it's a T-cell problem. It's an acquired T-cell problem, but they get CMV retinitis, CMV colitis, histoplasmosis, PCP, or PJP now, MTB. And as a matter of fact, when HIV first came on the scene, it was immunologists who took care of a lot of these HIV patients, because they were seeing the same type of infections that their congenital T-cell deficiency patients were having. Okay. What about B-cell defects? What do these patients get? Well, they get recurrent sinopulmonary infections. Okay. Why is that? Well, think about it. They don't have antibodies. They don't have IgG or IgM. And what's IgG important for? Well, fighting off encapsulated organisms. So they're going to get infections with strep pneumo, H. influenza, Staph aureus. They don't have mucosal defense, so they don't have IgA, so they can get enteroviral infections, Giardia infections as well. What about combined T and B cell defects? What do they get? Everything under the sun, okay? What about phagocytic disorders? These patients are going to get skin and organ abscesses, especially with bacteria such as Staph aureus. They'll also be really susceptible to catalase-positive organisms, in addition to Staph aureus, including Serratia, Aspergillus, Chromobacterium, Burkholderia, Nocardia. So if you get a clinical vignette on your boards and a patient has Burkholderia bacteremia, you want to think about, well, a phagocytic disorder or also cystic fibrosis. Okay? Complement deficiency. These patients can get overwhelming sepsis. With early complement, they get pyogenic infections and autoimmune disease. And with late complement, they get Neisseria infections, particularly Neisseria meningitis. Right. Now, we're going to go over the combined B and T cell deficiencies first. These include the SCIDS, or severe combined immunodeficiency. We'll touch upon Wiskott-Aldrich syndrome, ataxia telangiectasia, Bloom syndrome, and Megan-Breakage syndrome. Okay. So there's a whole, I think about almost 20 now, documented SCIDS. We won't go over all of them. We'll go over the main ones, such as IL-2 receptor defect and ADA deficiency. Now, SCIDS present within the first few months of life. These babies are really, really sick. They can have eczematous-like lesions all over. They can get chronic lung infections, pneumonias, chronic diarrhea, failure to thrive, absent thymic shadow, lymphopenia, septicemia. So if you have any baby that presents like this, always think about SCIDs. Okay. So what do these patients get? Again, T cell defects, B cell defects. They get intracellular organisms and opportunistic infections, recurrent sinopulmonary infections, because in order for B cells to produce antibodies, remember that T cells have to help. So when you don't have that, basically you don't have any antibodies, you don't have T cells working, you don't have B cells working. Okay. So the most common SCID is X-linked SCID. This is also known as IL-2 receptor defect. It's the most common form of SCID. It's found in over 50% of babies with SCID. And when you do phenotype expression, you'll see that there's, meaning flow cytometry, looking at the presence of T cells or B cells or NK cells, you'll notice that there'll be no T cells present, there'll be B cells present, but no NK cells present. Okay? It's caused by a mutation in the gamma chain. And the reason why this is important is because this gamma chain is used in several cytokine receptors such as IL-2, IL-4, and IL-7. So if the cells can't talk to one another, then you have a problem with your immune system. Okay? How do you diagnose this? Molecular analysis, and the treatment is bone marrow transplantation. You want to get these kids, babies, transplanted as soon as possible, because the outcomes are much improved if they get transplanted as quick as possible. All right. Adenosine deaminase deficiency. This occurs in 15 to 20% of the cases of SCID. If you do flow cytometry looking for T cells, B cells, and NK cells, you'll see no T cells present, no B cells present, and no NK cells present. Now, why is that? Well, ADA catalyzes the deamination of adenosine to inosine. So without this ADA, you have these toxic metabolites that build up, and basically it kills all of your cells. Kills all of your T cells, kills all of your B cells, and kills off all of your NK cells. So that's why you don't have any of these present when you start looking for them. So how do you make the diagnosis? You can look at low ADA levels in the red blood cells. And again, bone marrow transplantation at this point is usually the treatment of choice. If that's not possible, some centers have done enzyme replacement, but it's just not enough. Wiskott-Aldrich syndrome. Okay, so a nice mnemonic for this is EXIT. Okay, remember these kids have severe eczema. It's X-linked, so you'll see them in boys. They'll have immunodeficiency. They'll have thrombocytopenia, and the genetic defect is in a gene called the WASP gene, and it's located, as the name implies, in the X chromosome. And what you'll see is you'll see small platelets on peripheral smear. So if you've got thrombocytopenia and small platelets on your peripheral smear, it's Wiskott-Aldrich syndrome. Okay? Because any other time that you have thrombocytopenia, you're going to have large, platelets, megakaryocytes. Treatment is either with bone marrow transplantation, or if that's not possible, prophylactic antibiotics and IVIG. Ataxia-telangiectasia. All right. Don't you wish all the conditions were this easy? What do they get? Well, yeah, ataxia, they get telangiectasia, and they also get immunodeficiency. All right. The problem is not all the three symptoms occur all at the same time. They may have progressive symptoms. They'll develop ataxia first, then they'll get telangiectasias, and finally immunodeficiency. This is an autosomal recessive disease, and it's caused by a defect in the ATM gene, which is responsible for DNA repair. So, so therefore, these patients with the inability to repair DNA, they're at high risk of getting cancers, and they're susceptible to ionizing radiation. They get lymphomas, leukemias. The kind of interesting thing about these patients that's sort of good to know for the boards is that they have elevated alpha-fetoprotein. So if you have any child that presents with ataxia and elevated alpha-fetoprotein, really consider ataxia-telangiectasia. Now, Bloom syndrome is kind of similar to AT. It's a chromosomal instability disorder that's caused by a deficiency of DNA ligase. DNA ligase, as the name implies, puts together the DNA after it's been cut out and repaired. So these patients can get susceptibility to cancer, ionizing radiation, leukemias, and they also get immunodeficiency. Nijmegen breakage syndrome, this is caused by a defect in the NBS1, which produces nibrin. And again, it's also responsible for DNA repair of DNA breaks. It's also autosomal recessive. Clinically, they sort of have this burr-like facies, microcephaly, sort of a mild mental retardation, and also immunodeficiency. All right. So we just finished combined immunodeficiencies. Now we're going to move on to primary T-cell immunodeficiency. And there's not so many isolated primary T-cell immunodeficiencies. Why? Because in order for B cells to work, they need help from T cells. So the best examples I can give for isolated T-cell immunodeficiency include DiGeorge syndrome and Nezlov syndrome, which is a congenital thymic disorder. What do patients with T-cell defects get? Again, intracellular organisms, opportunistic infections, MTB, viruses, fungi, and PCP. So DiGeorge syndrome is sort of the prototypical T-cell defect, although they have also some B-cell defect as well too. And if you go way back in your embryology days, this condition results from the failure of the third and fourth branchial arches to form. Okay? The third and fourth branchial arches are important for the development of thymus, the parathyroids. It's also a migrational disorder, so these patients will also have congenital heart defects, such as VSDs, overriding aortas and whatnot, and also cleft lip and cleft palate. Because the thymus doesn't form, they have immunodeficiency. Okay, because the parathyroids don't form appropriately, they can present with seizures due to hypocalcemia, and in complete DiGeorge, they lack both T cell and B cell function. So a nice mnemonic for this is catch-22. These patients have cardiac problems, abnormal facies, thymic hypoplasia, cleft lip, cleft palate, hypocalcemia, and it's on the 22 chromosome. Now, just of note, not every single child with DiGeorge syndrome has immunodeficiency, so it's a huge spectrum of disease. Most of these kids are very mild. They have maybe some congenital heart defects or cleft lip, and then actually a small percentage of them, not a large percentage of them, have actual primary immunodeficiency. Okay? So now we're going to move on to primary B-cell immunodeficiencies. I'm going to talk about X-linked agammaglobulinemia or Bouton's agammaglobulinemia, common variable immunodeficiency or CVID, hyper-IgM syndrome, X-linked lymphoproliferative syndrome, and transient hypogammaglobulinemia of infancy. All right. So B-cell defects, right? Again, remember, what do B-cell defect patients get? They get recurrent sinopulmonary infections with encapsulated organisms, enteroviral infections, and giardia. So let's start off with X-linked agammaglobulinemia, also known as Bouton's agammaglobulinemia. So this condition is due to a mutation in something called the BTK gene. And what happens is during the maturation of B cells, they need this BTK Bouton's tyrosine kinase. So without this, the B cells are arrested in a pre-B cell stage. So you have no mature B cells present, and if you got no mature B cells, you can't produce any antibodies. So again, they're susceptible to encapsulated organisms, enteroviral infections, giardia. You get a child with recurrent ear infections, sinusitis, and pneumonias. Now, how do you make the diagnosis? You can do flow cytometry, again looking for those name tags on the cells. CD19 is the name tag for mature B cells. So if you look for CD19, it won't be present in patients with X-linked agammaglobulinemia. And because you've got no mature B cells, you've got no antibodies present, and you've got no antibody function. Okay? What do you do for these patients? You give them exogenous antibodies like IVIG or subcutaneous IG, subcutaneous IG. All right. Common variable immunodeficiency. There's a bimodal distribution, so you'll see it first within the first 5 to 10 years of age, and then you see it later on in adulthood. So what happens in this condition is that mature B cells are unable to differentiate into plasma cells. So what you have when you look for flow cytometry is you'll have CD19 cells present, but you have low antibody levels and poor antibody response. And again, similar to your X-linked agammaglobulinemia, these patients will develop recurrent sinopulmonary infections with encapsulated organisms, bronchiectasis. They'll get, again, enteroviral infections and Giardia infections. Now, what makes it different than Bruton's agammaglobulinemia is, one, these patients have mature B cells present. Okay, so that's a clue. They also get autoimmune disease. Okay, so they can get a sarcoid-like disease of non-caseating granulomas in their organs, such as the spleen, liver, lung, skin. They can get a sprue-like illness that causes diarrhea, malabsorption, and protein-losing enteropathy. And they're at increased risk of other autoimmune diseases. Well, you might think, well, wait a minute, that doesn't make any sense. I thought this is an immunodeficiency, whereas autoimmune disease is an overactive immune system. Well, it turns out it's an immune dysfunction, immune dysregulation. So now you've got, an immune system that's not working correctly. You've got constant bombardment by pathogens and a lot of inflammation going on. So that's a recipe for autoimmune disease. So that's why these patients get a lot of autoimmune disease. And they're also at risk for lymphomas as well, too, because of this constant inflammation and recurrent infection. All right, how do you make this diagnosis? Well, like I just mentioned, if you look at flow cytometry, you've got mature B cells present, you've got low antibody levels, and you've got no response to vaccination or very poor antibody function. Okay, so does everybody sort of understand what I mean by poor antibody function? Well, what we're looking at when we evaluate these patients, we're looking to respond to specific antibodies. So, for example, children are vaccinated with pneumococcal vaccine. So what we'll do is we'll actually check their pneumococcal titers to see if they've developed appropriate response to pneumococcal titers. And if not, we'll revaccinate them and recheck their titers. We do the same thing for diphtheria and tetanus, and that gives us a way to quantitatively evaluate B cell function. Okay? Now, how do you treat these patients? Again, you're missing the antibody, so you give exogenous antibody with IVIG or sub-Q IG. Now, I'm going to move on to X-linked hyper-IgM syndrome. This is caused by an inability of B cells to class switch. Now, as you all remember, the default antibody is IgM. And when you get an infection from interaction with T cells and macrophages, these B cells will then class switch to another type of antibody class. In order for these B cells to class switch, it has to interact with T cells through something called the CD40 ligand. Okay, so this is really important. So when you have a CD40 ligand defect, these B cells are not able to class switch, so all you produce is IgM. You don't produce any IgG or IgA or very low levels of it. And it turns out that the CD40 ligand is also important for T cell to macrophage signaling. So when these T cells can't communicate with macrophages, you're also susceptible to opportunistic infections such as PCP or PJP now. So not only are you susceptible to sinopulmonary infections, but you're also susceptible to opportunistic infections as well too, because your macrophages don't respond like they should. So this is kind of illustrating what I'm talking about. You have, in order for this B cell to class switch, you need not only CD40 ligand, CD40, and a whole bunch of other receptors for the T cells and the B cells to talk to one another. And so if you don't have CD40 ligand, you get this condition called X-linked hyper-IgM syndrome, where the B cell can't class switch and it only produces IgM. There's actually other forms where you have a defect in CD40. That's an autosomal recessive form. And then again, the B cells can't class switch, and all you have is IgM antibody present. Okay. How do you make the diagnosis? You can do flow cytometry, tag to the CD40 ligand, and if it's not present, then you make the diagnosis. Treatment is with bone marrow transplantation is really the best treatment. Okay. For less severe types or kind of less severe mutations, you can do also IVIG if possible, and also prophylactic antibiotics for PJB prophylaxis. Now, X-linked lymphoproliferative syndrome, also known as Duncan syndrome, these patients get overwhelming near-fatal infections with EBV. They get fulminant hepatitis. They can followed by bone marrow failure. And unfortunately, almost every single patient progresses to lymphoma. And the reason for this is the EBV virus triggers a sort of polyclonal expansion of B cells, and so they get lymphoma, unfortunately. This is due to a mutation in something called the SH2D1A gene. And it's just unfortunate because these patients don't do very well. Okay. Now, transient hypogammaglobulinemia of infancy. You may see a lot of this. This is a diagnosis of exclusion. What happens in these cases is it's thought to be a normal variant or prolonged period of physiological hypogammaglobulinemia that occurs between that nadir, that 4 to 6 month nadir. As we talked about before, the maternal IgG is consumed and starts to reach its nadir about 4 to 6 months. And in this condition, it's thought that the infant has a delayed antibody production. So it doesn't start making its own IgG until later, so it has a low Ig levels. But for the most part, these patients have good antibody responses, and basically all you need to do is observe these patients. And most of them will have normal antibody levels by 4 years of age. Okay? All right. So I know I've covered a lot with the B-cell defects, so I wanted to kind of go over everything in a nice table to make sure that you understand everything. So, you know, when you have a patient with recurrent sinopulmonary infections, and that's what they'll kind of give you on the boards. Now you want to think about 2 questions. One, are there enough cells that are needed, okay, for that particular pathogen? And 2, is it working properly? So you want to do both a qualitative and a quantitative evaluation, right? So with X-linked agammaglobulinemia, you want to ask, are there mature B cells? The answer is no. There's no mature B cells. Are there any antibodies present? The answer is no. And of course, there's no antibody response. Treatment, exogenous antibodies. Okay? What about common variable immunodeficiency, or CVID? Are there mature B cells present? The answer is yes, there are. Are there low antibodies? They're low because these B cells don't mature into regular plasma cells. You don't get enough antibodies, and there's no antibody or very poor antibody response. Again, treatment is with exogenous antibodies, or IVIG or sub-Q IG. Now, I didn't talk about this, but you may see it. I don't think they're going to talk about it on the boards because a lot of people don't believe this is sort of a true diagnosis. There's something called IgG subclass deficiency. Remember I told you that IgG comes in 4 flavors, IgG1, IgG2, IgG3, and IgG4. So in this condition, you have mature B cells present, but you have a specific low IgG subclass. Like, for example, you have IgG2 that's low. And the key in all this is you got to demonstrate poor antibody response, okay? Now, the reason why I don't think, or most people don't think this is a sort of a real condition is there's something called specific antibody deficiency. These patients have normal B cells, normal levels of antibodies, but they have a poor antibody response. So we kind of just lump all of the Ig subclasses into specific antibody deficiency because the treatment's the same. They need exogenous antibodies. Because the key thing you want to do is look at the function. Are the antibodies responding appropriately? And if not, then they need exogenous antibodies. Okay. Now, hyper-IgM, these patients have normal mature B cells, but they only have IgM present because, remember, the default is IgM, and they can't class switch to IgG and IgA and all the other antibodies. There's no antibody response because all they make is IgM, and treatment is with bone marrow transplantation. Transient hypogammaglobulinemia is a diagnosis of exclusion. Okay, so you want to follow these kids. These kids will have mature B cells, low antibodies present, but a pretty good antibody response, and usually you just need to observe, and that's it. Okay. All right, moving on to the next arm of the immune system, are phagocyte disorders. There are a host of congenital neutropenias, including Kostman syndrome, severe chronic neutropenia, and cyclic neutropenia. There's chemotaxic defects such as LAD, or leukocyte adhesion defect. And there's also killing defects like hyper-IgE syndrome, Shiraya-Higashi, chronic granulomatous disease, and specific granule deficiency, and we'll talk about each one. All right, let's start with the neutropenias. All right, Crossman syndrome is autosomal recessive. It's due to a mutation in the HAX1 gene, and these kids are just basically present with opportunistic infections due to neutropenia. There's also severe chronic neutropenia. This is autosomal dominant, and it's due to a mutation in something called neutrophil elastase. And there's something called cyclic neutropenia, where every 3 weeks to 6 weeks, they have these cycles of neutrophil levels. And this is also due to mutation in neutrophil elastase. And these patients, when they reach their neutrophil nadir, they'll develop some of the opportunistic infections. Now, phagocyte chemotaxis disorders, there's LAD1 and LAD2, extremely rare, but the board really loves this question, right? And what happens in these patients is that there is a defect in something called CD18. It's an adhesion molecule. It allows for neutrophils to kind of roll and stop and then migrate to the area of infection. So when you have this present, these neutrophils can't go to where they're supposed to go to. And so you have this infection that's called a sterile abscess because there's no neutrophils present, okay? You get this pronounced leukocytosis because the bone marrow is sensing that there's an infection present, but nothing's being done about it, so it just cranks out more and more neutrophils and leukocytes, okay? And you always hear this a lot. These patients will get delayed separation of the umbilical cord. So anytime you have that, you want to think about LAD. But more often than not, they'll get more severe symptoms, like they'll get really bad gingivitis, lympholitis, failure to thrive. Now, there's also a type 2, which is extremely rare. This is a defect in fucosylation of the Sal-Lewis moiety. Basically, it involves the rolling of neutrophils, and if they can't slow down and roll, they can't get to where they're supposed to go to, and you have similar sequelae. In addition, these patients will also have sort of abnormal phases, poor growth, mental retardation, and again, the sterile abscesses. Okay. Now we'll talk about some of the phagocyte killing defects. Right. Job syndrome, or hyper IgE syndrome, okay, is the name. It's also called Buckley-Job syndrome. And where the name comes from is from the biblical character Job, who was sort of smitten by Satan and was cursed with all these boils all over his body. And so that's where the name comes from, is that. These patients have abscesses and boils all over their body. The IgE is usually elevated, though not required, so it's kind of a misnomer that it's called a hyper IgE syndrome. In addition to the abscesses that I talked about, they also have scoliosis, hyperextensibility, delayed eruption of primary teeth, fractures, pneumatoceles, and coarse facies as well, too. Okay. Shide-Higashi. This is caused by impaired lysosome degranulation. This is autosomal recessive. These patients have partial occlucutaneous albinism, and they also get cutaneous and sinopulmonary infection. So if you have, someone who a vignette with, some partial albinism, recurrent infections, think about Shide-Higashi. Unfortunately, they also have mental retardation and a progressive peripheral neuropathy that's not amenable to bone marrow transplantation. Now, the key here is if you do a peripheral smear, you'll see giant granules. So you get that vignette with albinism, recurrent infections, and giant granules is Shide-Higashi. Okay. CGD, or chronic granulomatous disease, the most commonly is X-linked in transmission, about 70%. The other 30 are autosomal recessive, and it's basically an inability to generate the oxidative burst or respiratory burst. Okay, so these patients have recurrent organ abscesses, especially with catalase-positive organisms like staph, serratia. So anytime you get serratia bacteremia, really think about CGD. Also Burkholderia, Aspergillus, Chromobacterium, and Nocardia. So what happens is that the macrophages are not able to kill off these catalase-positive organisms. So what they do is they just basically surround them, and so you get these walled-off granulomas, and hence the name chronic granulomatous disease. Okay. How do you make this diagnosis? Before, we used to do something called the NBT test, or nitroblue tetrazolium. You basically put a few drops of the substance, and if it changes color, then you know that the respiratory burst is present. That's given way to something called the dihydrorhodamine test, which is much more accurate and can also detect carriers as well too. How do you treat these patients? Well, you give them prophylactic antibiotics against fungi and also staph, and you also give them interferon gamma, which sort of supercharges the macrophages so you can sort of overcome the problem with the inability to generate the respiratory burst. Specific granule deficiency. These patients lack primary and secondary granules that usually fuse together and is used for killing off organisms in phagosomes. Now let's move on to the next arm of the immune system, which is the complement arm. Now remember, there's early complement and late complement, or terminal complement. With early complement, these patients get severe pyogenic infections, and they're also at risk for autoimmune disease. And the thought is, because they have low complement, autoimmune causing antibodies aren't degraded by the immune system, so they're more prone to get autoimmune disease. For the patients with terminal complement deficiency, they get recurrent bacterial infections, especially with Neisseria meningitis. I don't know how many times this question has been on the boards. They seem to ask it all the time. A kid with Neisseria meningitis, what should you do? Think about complement defects. You want to screen with a CH50, and if it's undetectable or really, really low, then you can check the individual complement factors. Okay. All right. In terms of vaccinations for children who are immunocompromised, of course, you don't want to give them live vaccines. That's BCG, OPV, which we don't really give anymore, but MMR, varicella, live intranasal influenza, and smallpox. All right, so let's put everything together. I know that I've covered a lot of stuff. All right, so again, when you're presented with a scenario with a child with recurrent infections, you want to think about which arm of the immune system is defective. Is it the B cells? Is it T cells? Is it both T and B cells? Is it phagocytes, or is it complement? All right. So with a B cell defect, you want to do a quantitative evaluation. You want to see, are there B cells present? Okay, by doing flow cytometry. Remember that CD19 that we're looking for B cells? Are there enough antibody levels present? Okay, and then you want to do a qualitative evaluation. How is the antibody response? Do they respond to vaccination with pneumococcal? Do they respond with vaccination with diphtheria and tetanus vaccine? All right. What about T cell defects? Again, same thing. You want to look to see, are there T cells present? Okay. You can also do a CBC. All right, because remember, your CBC, the lymphocytes, about 80% of them are going to be from T cells, 20% of them are going to be from B cells. So most likely for patients with T cell defects, you're going to get lymphopenia. And then you can also assess T cell function by doing, a delayed hypersensitivity test. Basically what you do is similar to the PPD, but instead you use things that patients have already been exposed to, like Candida or MMR, and you look at the reaction after 48 hours to see if T cells are able to respond to foreign antigen. Okay. What about combined? You basically do both. Okay. Phagocyte defects, you want to think about CGD, LAD, right? And then complement, you want to differentiate whether it's early versus terminal, and then the CH50 is a very nice screen for complement deficiencies. All right. Now, there's one thing that I'm going to touch upon. It's not actually a immunodeficiency, but it may be on your boards. It's something called hereditary angioedema. And this is due to a defect in something called C1 esterase inhibitor function. Now, it's autosomal dominant. There's two types. Type 1 occurs when there's low levels of C1 esterase inhibitor. And type 2, where you have normal levels of C1 esterase inhibitor, but it doesn't function appropriately. So these patients will get recurrent episodes of angioedema, abdominal pain, extremity swelling, and possibly laryngeal edema, which may be life-threatening. Okay? Now, they don't get urticaria, so if you see someone with urticaria and swelling, it's not hereditary angioedema. They may get something called erythema marginatum, which is kind of a serpentinous type of rash, but they don't get urticaria. Okay? Now, how do you make this diagnosis? You can screen with a C4 level. Okay? Because you have constant complement activation, you're going to see a low C4 level, and if you see a low C4 level, then you can actually look at the C1 esterase function. And then after that, if that's low, you can do a C1 esterase inhibitor level to differentiate whether it's type 1 or type 2. Treatment. Before, we really didn't have much in terms of treatment. Patients got either attenuated androgens or danazol, which sort of caused the liver to produce more C1 esterase inhibitor, or if it's too hard to use, some people have tried aminocaproic acid. Now we actually have the C1 esterase inhibitor enzyme that we can actually give to patients for injection. Okay. All right, so let's go ahead and let's do some questions. All right. Ready? Remember, it's very simple, all right? All right, question number 1, all right? A 2-month-old boy is brought to your emergency room with respiratory distress, tachypnea, and hypoxia, all right? The child is noted to have a dry, scaly rash and is less than 5 percentile for weight. It's fair to thrive. You look on the chest x-ray, and there's bilateral hazy infiltrates and an absent thymus. Okay? What is the best test to evaluate this patient's diagnosis? Okay? Is it A, CH50 with quantitative C3 and C4, alpha-1 antitrypsin level, quantitative IgG subtypes, flow cytometry for T and B cells, flow cytometry for CD11 and CD18? Very good. Most of you got it right. Okay. So this patient has, all the findings of common variable immunodeficiency. All right. It's coming in with what appears to be an opportunistic infection with PCP with bilateral infiltrates. There's no thymus present. It's fair to thrive. Okay. So you want to look for T and B cells to see if they're present or not. And then you can do specific, phenotyping and molecular analysis for the specific type of severe combined immunodeficiency. Right. Question number 2. A 4-year-old boy comes to your clinic with a history of eczema, multiple admissions for pneumonia, and a history of easy bruising. What test can help you confirm the diagnosis? Is it A, dihydrorodamine test, small platelets on peripheral smear, C1q inhibitor levels and function, diphtheria vaccine titers? Okay. All right, good. Most of you got it right. All right. So, this is classic for Wiskott-Aldrich syndrome. Remember the exit mnemonic? Patients have eczema, all right? It's X-linked. It's a boy. Immunodeficiency with the recurrent sinopulmonary infections and thrombocytopenia. And so if you have thrombocytopenia and small platelets on peripheral smear, that's virtually diagnostic for Wiskott-Aldrich syndrome. All right, question number 3. 4-year-old boy comes to your clinic with a history of frequent falls, recurrent pneumonias, and multiple admissions and an elevated alpha-fetoprotein. What is the most likely diagnosis? Is it A, Wiskott-Aldrich Bombay variant, ataxia telangiectasia, lymphocyte adhesion defect type 2, or Duncan syndrome? Okay, yeah, most of you got it right. Ataxia telangiectasia with the frequent falls, okay? And the telangiectasias may not occur until later on. So with this elevated alpha-fetoprotein, it seems pretty clear that this patient has ataxia telangiectasia. Okay. Next question. An 8-month-old boy comes to be evaluated for a history of recurrent otitis media and pneumonia and a family history of an uncle who had a similar problem who died at about 1 year of age. Which of the following tests should be done next in the workup? Is it A, quantitative immunoglobulins, flow cytometry for T cells, NBT, chest x-ray to evaluate for the presence of a thymus? Very good. Quantitative immunoglobulins, all right? Okay. The second one was NBT. Now, NBT would be for chronic granulomatous disease, and that's not the right answer because those patients will get a lot of more serious infections with the catalase-positive organisms. This patient has recurrent sinopulmonary infections, so you want to look at their immune globulin levels. Okay. All right, question 5. A 4-month-old boy is admitted to the PICU for PJP pneumonia, or formerly PCP pneumonia. The patient is 75 percentile for height and weight. Initial immune workup shows absent IgG levels, absent IgA levels, and normal IgM levels. What is the most likely diagnosis? Is it A, SCID? Is it B, CVID? Is it C, specific antibody deficiency? Is it D, hyper IgM syndrome? Or is it E, X-linked agammaglobulinemia? All right, very good. Hyper IgM syndrome. Okay, so this kid doesn't have failure to thrive, but he does only make IgM. So the correct answer is hyper IgM syndrome. It's not SCID because with SCID you wouldn't have any antibodies at all basically, and the child would have failure to thrive. All right, so we made it all through immunology. Everybody take a deep breath and big sigh of relief. Whew, okay, and then we're going to move on to allergic reactions. All right, okay, so we're going to talk about the different types of allergic reactions. If you look at the Jelen-Coombs allergic reaction, there's type 1, type 2, type 3, and type 4. Okay, type 1 is the immediate hypersensitivity reaction, which is IgE mediated. Type 2, or cytotoxic, is IgM or IgG mediated. Type 3 is immune complex. Think about antibody-antigen complexes. And then type 4 is the delayed reaction, which is T-cell mediated. And we'll go over each one. All right, so type 1 is your classic allergies. It's your allergic rhinitis, your hives, your food allergy, latex allergy. They're all IgE mediated. And there's an acute phase and there's a late phase. Okay. Now, the acute phase occurs within minutes to 1 hour after exposure, and it occurs when antigen binds to IgE antibodies. Then these IgE antibodies, which are on mast cells, cross-link and cause the mast cells to degranulate. And what do they degranulate? Well, they release histamine, they release leukotrienes, they release prostaglandins and cytokines, and so you get that allergic reaction. So with H1 histamine, you get that wheal and flare reaction, like hives. You can get bronchoconstriction. You can get pruritus. With H2, or type 2 histamine, you get increased gastric acid secretion. Okay. Now, the late phase can occur 3 to 12 hours after the acute phase. It can last for hours to days. And what happens is, after the mast cell degranulates, it also releases a lot of cytokines. Okay? And these cytokines, or chemokines, causes other cells to move in, to infiltrate the area, such as eosinophils and basophils. And then these eosinophils and basophils release their contents, and so you can get this kind of late phase reaction after your initial type 1 allergic reaction. All right, type 2 is cytotoxic. Okay, this occurs when IgM or IgG antibodies bind to fixed tissues or cell receptors. When you have binding of the antibody to these target tissues, it causes a cell destruction. So you can get complement activation, You can get opsonization, and you can also cause phagocytes to attack the antibody-coated cells. Okay? So these are some examples. With fixed tissue antigens, you can get antibodies to the basement membrane, for example, and so you can get Goodpasture syndrome. You can get antibodies to the acetylcholine receptor on muscles, and the result of that is myasthenia gravis. When you have target cell receptors, you can get antibodies to platelets or red blood cells or white blood cells, and you can get, for example, autoimmune thrombocytopenia or autoimmune hemolytic anemia and autoimmune leukopenia as well. Now, type 3 reactions are immune complex. You want to think about vasculitis, okay? These immune complexes form when antibodies combine with antigen, and there's significant precipitation when there's a slight antigen excess, okay? Then these immune complexes start to precipitate in small vessels, hence you get the vasculitis. They activate complement, causing inflammation. You can get necrosis of the blood vessels, which causes a leukoclastic vasculitis. And you can get basically hemorrhagic lesions from this vasculitis. So examples of this include serum sickness. Okay, this occurs when a large amount of antigen is injected into a non-immunized animal, or the Arthus reaction, which is more of a localized reaction where you have a hyperimmunized animal, and you give an injection of the antigen, and these antigen-antibody complexes precipitate, and you get all the problems as mentioned. All right, serum sickness occurs about 1 to 3 weeks after administration of a drug. Clinically, patients will have fever, rashes, joint pain, lymphadenopathy, muscle aches, proteinuria. You have these kind of characteristic skin findings, or sort of a classic serpentiginous rash on the hands and feet. But you can also get other rashes such as urticaria or angioedema as well. They can get involvement in the joints, where you can get arthralgias or frank arthritis. And then you can get immune complex deposition in the GI tract causing nausea and vomiting. A lot of causes for serum sickness. The main ones include equine anti-tetanus, antibiotics can cause it, especially within the penicillin family, ATG, OKT3, and also venom stings can also cause this sort of serum sickness as well too. Now, type 4, as you all know, is a delayed reaction. It occurs 24 to 72 hours. This happens when previously sensitized T cells interact with antigen. Examples of this include contact dermatitis and tuberculin sensitivity. And you guys are all familiar with this because you guys do this all the time. You want to see if the patient has TB. So what do? You inoculate the patient with the PPD, which is a tuberculin-derived derivative, and antigen-presenting cells take up that tuberculin. It migrates to lymphocytes where there's T cells, and if the T cell has seen that tuberculin before, it causes an inflammatory response. So 48 to 72 hours later, you get that induration there. So that signifies this patient has been exposed to tuberculosis, at least latent tuberculosis. Okay? Now there's something called a type 5, which is an autoimmune stimulatory reaction. Basically, IgG antibodies, instead of inhibiting the receptor, actually stimulates it. So the best example of this is Graves' disease, where you actually have IgG autoantibodies, which have a stimulatory effect on the TSH receptor, and you can get hyperthyroidism. Okay. All right, now we're going to talk about anaphylaxis. As you all know, this is IgE-mediated. Common causes include antibiotics, drugs, foods are well-known culprits. Latex allergy, anesthetic agents, especially induction agents or neuromuscular blocking agents, and also insect stings as well too. All right. Now, anaphylactoid, you may hear that a lot. Basically, it's clinically indistinguishable from anaphylaxis. The only reason it's anaphylactoid is because it's not IgE-mediated, because we can't find any specific IgE antibodies to whatever is causing the reaction. It results in direct mast cell degranulation, so it's IgE receptor independent. And so there's certain anaphylatoxins such as C3A, C4A, and C5A, which can induce mast cell degranulation without the IgE receptor. So examples of this include aspirin, NSAIDs, for some of those patients, radio contrast dye allergy, and also sulfite allergy as well. Okay. Both anaphylaxis and anaphylactoid reactions usually occur 5 to 30 minutes, hence the name immediate hypersensitivity reaction. After antigen exposure, you have multiple systems involved. The skin manifestations are the most common, but just because you don't have it doesn't mean you can rule it out. Of course, you can get respiratory symptoms like bronchoconstriction, full-blown cardiac collapse with hypotension, GI manifestations of abdominal pain, nausea, and vomiting as well. How do you treat? Epi. The first line is always epinephrine, okay? So they looked at people who unfortunately died from anaphylaxis, and two of the most common reasons were failure to recognize the signs and symptoms of anaphylaxis, especially those patients who didn't manifest cutaneous symptoms, and also failure to administer epinephrine early on, okay? How much do you give? It's 0.01 milligrams per kilogram of a 1 to 1,000 dilution. And the recommended area is intramuscularly at the anterior lateral thigh. Okay? They've done studies showing epi levels, and this is where it achieves the best levels. How does epinephrine work? Well, it has both alpha and beta adrenergic effects. It causes bronchial relaxation, vasoconstriction, and decreased vascular permeability, basically trying to reverse all the symptoms and signs of anaphylaxis. Now, what about patients who are on beta blockers? Well, definitely beta blockers are contraindicated in patients who are at risk for anaphylaxis. Okay, so you definitely don't want to have a patient on beta blocker if they have a severe like bee allergy and they're a beekeeper, for example. Okay. Now, epinephrine is still first line. Okay, so you give epinephrine first, but if they're non-responsive, you can also give them glucagon or vasopressin. Okay, for those patients who are non-responsive to epinephrine. And the way glucagon works is it's through a beta receptor independent pathway. It works through cyclic AMP, and it can sort of reverse some of the signs and symptoms of anaphylaxis. So your treatment, again, remember the ABCDs, airway, all right, check their airway. You can give inhaled albuterol if they're wheezing, intubate if necessary, circulation, volume resuscitation, because in addition to the vasodilation, you also get a lot of pulmonary leakage and capillary leakage. So they will have reduced intravascular volume, so you want to resuscitate that if they have hypotension. And then in terms of drugs, epi is always first line. You can also give H1 and H2 antagonists for symptomatic relief. And then steroids may prevent late phase reaction. But remember, steroids don't take effect until 4 to 6 hours later. Okay. So I'm going to move on to urticaria. And when we talk about urticaria or hives, we usually differentiate between acute versus chronic urticaria. And that's important because it sort of, the way we evaluate urticaria is different. If it's acute, it means that the hives are lasting less than 6 weeks in duration. So all these are IG mediated. So we look for the common culprits such as food, drug, pollen, insect sting, allergy. Now, if it's chronic, hives lasting more than 6 weeks, unfortunately, a lot of these cases are idiopathic. And I would say even 95% of these cases are idiopathic. Of the few cases where we do find a cause, thyroid disease, autoimmune disease, malignancy, and chronic infection. But for the most part, it's idiopathic. Now, there's some interesting urticarias called physical urticarias. One example is an acquired cold urticaria, and these patients actually can get hives just from cold exposure. And they can actually die if they jump into a cold swimming pool. So it's very important when you make the diagnosis to tell them not ever jump into cold water or anything like that, wear warm clothing all the time, because they can actually die. And how do you make the diagnosis? You actually do an ice cube challenge. You basically put an ice cube on their forearm for 5 minutes, and then you remove it, and on the rewarming phase of their forearm, you actually see the hive sort of appear. It's kind of really neat. There's other physical urticarias called cholinergic urticaria. These are very, very common. A lot of patients will call this kind of a heat rash. When it's hot, they'll have like small kind of punctate hives that's very pruritic. Then there's all sorts of other physical urticarias, which I won't get into, like vibratory urticaria, aquagenic urticaria as well, too. Just kind of neat if anybody wants to go into allergy and immunology. All right. Anyway,
Urticarial vasculitis. So this is something you need to know because you'll see a lot of patients with hives, and you want to fish out the ones who need a lot of attention and need referral immediately. So you want to rule out autoimmune disease. So what are some of the red flags for urticarial vasculitis? Well, first of all, if the lesions last more than 24 hours in a fixed location. And what that means is if they move from one spot to another, then that's okay. But if there's one particular hive that stays for more than 24 hours, then that's a red flag. If it leaves any kind of ecchymosis or hyperpigmentation or purpura, that's a red flag. And these hives are burning and painful, that's a red flag. And of course, if they have any other systemic symptoms such as frank arthritis, fevers, or fatigue, then that's a sign of urticarial vasculitis. And you want to refer them to dermatology, get a skin biopsy. You can also check C3 and C4 levels, which will be low, and also antibodies to C1q to make the diagnosis. All right, asthma. Okay, I won't spend too much time on asthma because, again, I think the pulmonary section spent time on it. But basically, asthma is a chronic inflammatory disorder of the airways that's characterized by reversible airflow obstruction, okay? And it's characterized by recurrent episodes of cough, wheeze, chest tightness, and shortness of breath. Those 4 symptoms, okay? You don't have to have all of them, as you all know. Just, cough is just one symptom is enough. And if you look at the 2007 NAV guidelines, it's over 400 pages, so I'll try to simplify it for everybody with the rule of 2s, okay? Because you guys, of course, have all read it, right? Just kidding. All right, so they mention control. Now, control is the degree to which the manifestations of asthma are minimized and the goals of therapy are met. So they separate control under impairment, which is what we used to call symptom frequency. So if a patient has less than 2 times of daily symptoms per week, or less than 2 times of nightly symptoms per month, or need less than 2 times of their short-acting rescue medication, then they're considered controlled. Now, there's a new domain within the guidelines which includes risk. This is an assessment of their morbidity, okay? Now, what predicts a future ED visit or hospitalization is a past ED or hospitalization. So if the patient has had 2 or more ED visits or hospitalizations per year, that means they have risk, and that means their asthma is not well controlled, okay? Now, I won't go over this too much. You guys all know this. Relievers, albuterol, controllers. The gold standard is inhaled corticosteroids. There's other alternative medications, including leukotriene receptor antagonists, such as montelukast, and also long-acting beta agonists, like formoterol and salmeterol. And these long-acting beta agonists, as you all know, should always be used in combination with inhaled corticosteroids. Now, there's something that the pulmonologist may not tell you. There's something called the Asthma Predictive Index, and I think this is pretty important because, if anything, before when a child came in with wheezing and had multiple ED visits and whatnot, and the parent, and he's like 3, and you ask them, the parents ask you, is my child going to have asthma when Johnny gets older? And you made something up, say, well, yeah, maybe, maybe not, sure, of course, whatever. You really didn't know, okay? So with this asthma predictive index, all right, if a child has had more than 4 episodes of wheezing per year, all right, and they've got 1 major criteria or 2 minor criteria, okay, they have a positive predictive value of 76% that they're going to develop asthma when they're 6 years old. If it's negative, it's a very good negative predictive value of 95%. Okay, so you actually can tell parents now what is the likelihood that your child who wheezes all the time is going to develop asthma when they're 6 years old. I mean, truth be told, it's hard to diagnose a child at 3 years old with asthma. One, you don't have any objective measures of lung function. You can't do that unless you go to a special lab and do body plasmography. You can't get objective lung function. And 2, 50% of children wheeze anyway. They can get bronchiolitis, from viral infection. That's probably more common than asthma. So with this, if you have 1 major criteria, which is either one of the parents have asthma or the child has eczema, or you have 2 minor criteria, the child has either allergic rhinitis, wheezing apart from colds, or if the child has eosinophilia, you can say, a positive predictive value at 6 years of age, 75, 76% that the child will develop asthma. Okay? Now, allergic rhinitis. Now, rhinitis, there's several different varieties. You can have allergic rhinitis, and you can get seasonal, you get perennial, or you can get perennial with some seasonal exacerbation. There's also something called non-allergic rhinitis of eosinophilia, vasomotor rhinitis, and rhinitis medicamentosa. Okay, so allergic rhinitis, seasonal, most common things that can trigger their rhinitis, grasses, trees, weeds. Perennial include dust mites, mold, animal dander. And the cardinal symptoms of rhinitis include congestion, rhinorrhea, sneezing, itchiness. And all this is IG mediated. If you do a nasal smear, you see a lot of eosinophils in there. Okay. You guys know all this. On physical examination, you can get the Denny-Morgan lines or the wrinkles below the eyes, allergic shiners, the nasal salute, that crease across the nose from constant rubbing. If you do on your physical examination, the turbinates will be swollen and pale. There may be some cobblestoning from postnasal drip. If you do see nasal polyps in the child, it's not allergic rhinitis. You want to think about other entities such as cystic fibrosis and also allergic fungal sinusitis. And that's something probably the boards will try to probably emphasize, okay? How do you treat? Well, the triple A's, avoidance, okay? You can do, RAS blood testing to see what they're allergic to, or send them to allergy, do skin testing. Antihistamines are first-line therapy, but also nasal steroids are effective as well, too. They're actually more effective than antihistamines. And then last but not least, allergy shots. Avoidance, what do you tell your patients? Well, if they're allergic to certain things, you tell them to avoid pollens. Tree pollens usually are highest in the springtime. Grass pollens are usually in the summer, and weeds in the fall. You want to tell them to close their windows, get home air filter systems. If they have dust mite allergy, tell them to buy impermeable mattress and pillow covers. Decrease the humidity by less than 50% because dust mites really thrive in high humidity areas. And you want to wash your sheets in 140 degrees of hot water every week. In terms of pet, this is a tricky one because they're probably likely to get rid of you rather than get rid of the dog. But you tell them the best thing is to at least remove the cat or dog as far from them as possible, outside, or at the very least not in the bedrooms, okay? And a HEPA filter or air filter may be helpful as well, too. Okay. All right, antihistamines are useful for treatment of allergies. Now, the early generation antihistamines cause sedation. These include the diphenhydramines, the chlorpheniramines, and hydroxyzine. This is because they cross the blood-brain barrier, and they interact with dopamine and serotonin and acetylcholine receptors. Because they interact with acetylcholine receptors, you can get blurry vision and dry mouth as well, too. A lot of patients may complain about that. The second generation antihistamines are much less likely to cross the blood-brain barrier. These include cetirizine, fexofenadine, loratadine, and desoloratadine. Actually, fexofenadine doesn't cross the blood barrier at all, so it doesn't cause any sedation. Allergy shots or allergen immunotherapy. Now, this only works for IgE-mediated conditions, okay? And what you do is we give increasing doses of allergens to patients to induce immune tolerance. And remember those T regulatory cells that we talked about? These T regulatory cells come into play. They secrete a lot of suppressive cytokines such as IL-10 and TGF-beta. And they also can cause produce blocking antibodies to IgE. So basically, they sort of induce an immune tolerance to the allergen. All right. Now, non-allergic rhinitis of eosinophilia syndrome, or NARES. These patients can have chronic nasal congestion. When you do the nasal smear, there's eosinophilia. But when you do the RAS test or the allergy skin testing, they're not really allergic to any allergens. Vasomotor rhinitis, this is due to a reaction to neurogenic or vagal stimuli, and the kind of most known example of this is like gustatory rhinitis, where a lot of patients will eat certain foods and their nose starts dripping, or skier's nose. You go outside in the cold and the nose starts dripping, or they may get sneezing attacks from even some things as exposure to sunlight. And it's thought to be neurogenically or vagally mediated. Rhinitis medicamentosa is due to a rebound congestion from overuse of vasoconstricting nasal drops such as phenylephrine, oxymetazoline, and nafazoline. Okay, and that's why you don't want to tell patients to take any of these medications for more than 3 days, so that you can get a severe rebound congestion and it's difficult to get them off of it. Okay, all right. Atopic dermatitis, something you'll see very often in your practice. It's a chronic relapsing inflammatory skin disease associated with allergy. Remember, it's the itch that rashes. So if anybody comes in with a rash that doesn't itch, it's not atopic dermatitis. It's itchy, 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 very, very itchy. All right, now there's something that you probably all heard of, the atopic march, where a lot of patients with atopic dermatitis will then develop allergies and then they'll develop asthma later on in life. What are some of the clinical features? Pruritus, chronic relapsing course. Okay, there's a typical distribution. They involve usually in younger children the face and extensor surfaces, and in older children and adults the flexor surfaces. And there's usually a personal family history of atopic disease. Okay. How do you treat? Well, I like to use this pyramid, right? In terms of treatment, you want to start off with moisturization. That's very key because atopic dermatitis is an impaired skin barrier. So if you don't moisturize the skin, it's not going to be effective. So you've got to moisturize. And so why is it that the skin hygiene and moisturization is really important? Well, studies have demonstrated that there's an enhanced transepidermal water loss. Okay, it's due to an impaired function of the water permeability barrier. So there's a lot of decrease in the water content of the skin, so you have to constantly moisturize the skin for these patients. All right. Next treatment pyramid is the use of immunosuppressants. Topical steroids are the mainstay of treatment for atopic dermatitis. They come in different preparations, from ointments to lotions to creams. Ointments in general are better than creams in terms of bioavailability, but they're also more occlusive as well too. So when it's really hot outside like it is right now, it can cause occlusion and cause itching and folliculitis. And in that case, creams might be better when it's really hot. Now, there's also other immunosuppressants such as topical calcineurin inhibitors, such as tacrolimus and pimecrolimus. Okay. These bind to the FK506 binding protein and inhibit signal transduction of T cells and also pro-inflammatory cytokines that are released by T cells. So they work pretty effectively. Both of these, the tacrolimus and pimecrolimus, are approved down to age 2 years of age. Okay. Antihistamines. Now you want to really break the scratch cycle, because what happens is because it's itchy, the child will scratch, it gets more inflamed, more irritants get in there, it gets more itchy, and you kind of go through this vicious cycle. So first generation H1 blockers are more effective, but they also cause sedation. So you can do the newer generation ones. H2 receptors are also found on the skin, like ranitidine and famotidine. About 15 to 30% of them are on the skin, so they may be of value as well too. You want to avoid topical antihistamines because they can cause sensitization. Okay. Now the next thing, if all this doesn't work, is you can try wet wraps. Okay, and these sometimes are very helpful for patients who are constantly scratching. They have a lot of excoriation and trauma for their skin. By doing the wet dressings, you reduce the itchiness and you reduce the inflammation by cooling down the skin. It also acts as a nice barrier to all that trauma that's going on. And it also improves some of the penetration of the immunosuppressive agents as well. Okay. And then finally, antibiotics may play a role, but I would probably reserve that as a last resort. Okay. And the reason being for this is what they found was that a lot of patients with atopic dermatitis are actually colonized by Staph aureus. About 90% of these patients are colonized compared to only 5% of normal controls. And of those patients who are colonized, 50% of them produce this super toxin, the Staph aureus TSST1. And so if you basically got rid of the Staph aureus, you don't have this production of the super toxin, and you have less inflammation going on in the skin. All right. So you can use any kind of systemic antibiotic therapy that treats for Staph aureus. You can also do topical ones as well too if it's a localized area. The key thing is you don't want to do maintenance antibiotics because it can result in obviously MRSA colonization. All right, next we're going to talk about food allergies. These are pretty important because it's getting more common. You're going to see it more often. It affects about 6% of children. It's the leading cause of anaphylaxis outside of hospitals, and it's very common in children of atopic dermatitis. As a matter of fact, about a third of patients of atopic dermatitis have a particular food allergy. What are some of the most common food allergies? Well, 85 to 90% of a food allergy will be from wheat, eggs, milk and soy, peanuts, and tree nuts, and seafood. Okay? So nice mnemonic is WIMPs. All right, WIMPs. All right, so how do you make the diagnosis? The history and physical is extremely important. Okay. Again, food allergies are immediate hypersensitivity reactions, so it's going to be something that they ate and have symptoms within minutes to the latest 2 hours or so after they eat it. It's not going to be something from the next day. Okay. And then you confirm the food allergy with either skin test, okay, which is very good in terms of ruling it out, has a very high negative predictive value of 95%, but very, very low specificity, okay? So it's only about 50%. So when someone is positive to certain food, it only indicates sensitization. It doesn't indicate clinical reactivity. You have to always correlate it with a clinical history, okay? The same thing applies with the RAS test. It's a little bit less sensitive than the skin prick test, okay, but it has kind of low specificity. Now, having said that, there are some cutoff values for the RAS test which have been shown to have a high clinical likelihood of having a true reaction. These, you don't need to remember this, it's just kind of note for yourself. Certain foods like eggs, milk, peanut, codfish, with these certain cutoff points, there's a more than 95% chance of a clinical reaction. So how do you make the diagnosis? Well, the gold standard, just for all to know, is a double-blind, placebo-controlled food challenge. No one really does that. It's very time-consuming, difficult to do. Usually just an open challenge is sufficient. How do you treat an actual food allergy, allergic reaction, avoidance, and if it's severe where they may have some respiratory problems, epinephrine. Okay. So what's the natural history? All right, what do you say when parents ask you, well, is Johnny going to outgrow his egg allergy? Well, the answer is yes, most likely. Most children will grow out their allergy to milk, egg, wheat, and soy, about 85%. Unfortunately, if you're allergic to peanuts, tree nuts, and seafood, they tend to persist well into adulthood and continue on. So only about 20% of kids will outgrow their peanut allergy. All right, so next I'm going to talk about adverse drug reactions and specifically allergic drug reactions. The World Health Organization defines an adverse drug reaction as any noxious, unintended, or undesired effect of a drug that occurs at doses used for prevention, diagnosis, and treatment. Cutaneous reactions are the most common. 15% of patients sustain adverse drug reactions during their hospitalization, so not a small number. And of those, about 7% of those patients experience very serious adverse drug reactions. So there's several different types, type A and B, and I'm just going to focus just on the allergic type. Okay. So type 1 is the immediate hypersensitive reaction. Again, it occurs within minutes to hours. It is caused by IgE cross-linking that releases mediators from mast cells. You can get urticaria to full-blown anaphylaxis. Examples of this include, the drug notoriously penicillin. Penicillin works as a hapten. And so what haptens are, they are chemically reactive small molecules, and they covalently, by themselves, they're not reactive or immunogenic. But when they covalently bind to self-proteins, that's when they become immunogenic and cause these allergic drug reactions. Type 2 drug reactions occur days later. They're cytotoxic reactions. So what happens is IgG or IgM antibodies recognize the drug antigen on the cell membranes. In the presence of complement, the antibody-coated cell is cleared by the monocyte macrophage system. So examples of this include drug-induced hemolytic anemias and thrombocytopenias. Some common culprits include methodopa, penicillin, and cephalosporins. Okay. Type 3 drug reactions are immune complex mediated. That means they're going to occur 1 to 3 weeks after administration of the drug. These immune complexes deposit in blood vessel walls, activate complement, cause inflammation, cause vasculitis. So patients will present with fevers, rash, urticaria, lymphadenopathy, and arthritis and arthralgias about 1 to 3 weeks after administration of the culprit drug. Examples of serum sickness, ATG, thioureols, and phenytoin have all been shown to cause drug reactions with serum sickness. Now, your type 4 delayed reaction occurs 48 to 72 hours afterwards. These are mediated by T lymphocytes. An example of this is your contact dermatitis with your local antibiotics such as neomycin or local anesthetics, and also topical antihistamines. All right. Insect allergy. About 1% of children will have systemic reactions to insects. The most common of these are from the Hymenoptera order. That includes bees, yellow jackets, hornets, wasps, and also ants, fire ants. So if a child has had a previous systemic reaction, the chance of him having another future systemic reaction is about 10 to 15%. All right. Note that allergy shots for insect or venom immunotherapy is extremely effective in preventing these future systemic reactions, on the order of more than 98%. Okay. So where are these things located? This may be helpful in a clinical vignette if the hornets' nests are found attached to the outside of trees, bees are found on the inside of trees, wasps are kind of found on the eaves of roofs, they're kind of dangling there. Yellow jackets are more lower to the ground in cracks, in trashes, and old buildings and shrubs, and fire ants are on mountains, obviously. So who needs to be evaluated for insect allergy, and who needs basically allergy shots for insects? So this is a nice table showing, what's the future risk of an insect sting, and I'll show you why this is kind of important. So if you've never had a reaction, okay, your risk of a future systemic reaction is 17%. If you've had a local reaction, your risk of a future reaction is 10%. Now, if you're a child and you have a cutaneous systemic reaction, meaning you have hives all over your body, okay, your risk of a future systemic reaction is only 10%. However, if you're an adult, you're unlucky, your risk of a future systemic reaction is actually 20%, okay? If you have anaphylaxis, that child has a 40% chance in the future of developing a systemic reaction, and the adult has a 60% chance. Now, why did I bring this out? Well, who gets immunotherapy and who gets evaluated? Well, the only child, all right, that needs an evaluation is a child who has anaphylaxis from a venom sting, okay? Because if you just get hives, your risk of a future systemic reaction is only 10%, and that's actually less than someone who's had no reaction at all. Okay, so they may ask some type of question like that. What's the next step? And if it's only a systemic, like hives, and that's it, no throat tightness, no respiratory distress, then you don't need any further evaluation. Does that sort of make sense? No? Now, all right. So, like I was just mentioning, you only refer or you only need evaluation only if the child has had anaphylaxis to insect stings. Adults are different, but you guys don't care, so it's good. Okay. All right, latex allergy. Okay, so latex is made from the hevea tree. Okay, and it's a frequent cause of anaphylaxis in children and healthcare workers. All right, who are at high risk: children who have spina bifida, children who have congenital urological problems, especially if they've had multiple manipulations and surgeries in the past. Okay, this is an Ig-mediated reaction to the hevea protein. Okay, now latex allergy, interestingly enough, there's a lot of cross-reactivity with other fruits and vegetables. And some of the patients who have latex allergy may also be allergic to papayas, kiwis, bananas, figs, potatoes, avocados, tomato, and chestnuts. Okay? Why that is, I don't have the time to go into, but trust me, they do. Okay. All right, mastocytosis. Okay. Now, mastocytosis is a rare disorder, and it's caused by abnormal proliferation of mast cells, okay, and it can accumulate in different various organs. And the degree of involvement or symptomatology depends on the extent of the disease. So the main types include cutaneous type or urticaria pigmentosa, systemic mastocytosis, which is pretty severe, or even malignant mastocytosis, which is very, very severe and fatal. Okay. Now, cutaneous mastocytosis basically results in abnormal proliferation of mast cells in the skin. It causes urticaria pigmentosa. These patients have this derriere sign, which is kind of very interesting. They have these macules, which are the urticaria pigmentosa, these brownish macules, and just by gently stroking the macules, they actually have a wheal form. And if they're very, very sensitive, they can actually start having some allergic anaphylactic reactions, as a matter of fact, because the mast cells actually degranulate, and they can actually have some bronchoconstriction and whatnot just by stroking the macules. How do you screen for this condition? You can check a tryptase level, and if it's above 20, then it's most likely due to cutaneous mastocytosis, and you can call the dermatologist to get a biopsy for confirmation. Okay. Systemic mastocytosis occurs when you have mast cells in other tissues. You can have it in the liver, heart, lungs, GI tract especially. These patients can have very bad abdominal symptoms, fatigue, recurrent episodes of anaphylaxis, in addition to the urticaria pigmentosa. How about malignant mastocytosis? Again, very severe systemic symptoms. Usually they don't have much in terms of the skin manifestations, but they can get hepatosplenomegaly, lymphadenopathy. How do you treat these patients? Well, you want them to avoid things that can cause mast cells to degranulate on their own. That includes cold weather, extremes of heat, alcohol, aspirin, and opiates. Okay, oral cromolyn can sort of help GI symptoms. Various chemotherapy have been used for malignant mastocytosis. Unfortunately, it's not very successful. All right, so we've got some time for questions. Okay, so let's do some questions. A 17-year-old boy has recurrent episodes of angioedema without urticaria. Previous treatment with epinephrine and steroids has had little effect. What workup should be done at this point to work up his condition? Is it A, C1 esterase inhibitor level and function, mannose binding lectin level and function, C6 level, skin testing to pollens? All right, very good. C1 esterase inhibitor level and function. Clearly this patient has hereditary angioedema, and that's the right diagnostic evaluation for that condition. All right, a 15-year-old girl is given a new medication for seizures. About 2 weeks after starting her medication, she began having urticaria, fever, arthralgia, and malaise. What category of hypersensitivity reaction does her reaction fall into? A, type 1, B, type 2, C3, D4. All right, very good, type 3. So remember, type 3, think vasculitis, okay? So all her symptoms are consistent with a type 3 antibody antigen-mediated reaction. Question number 8. A 5-year-old boy with a history of cardiac condition and peanut allergy comes for well child care. After eating a candy bar, he develops hives and throat tightness. His mom informs you that he is taking carvedilol and digoxin. What is the next appropriate step? A, discontinue carvedilol. B, give him diphenhydramine, C, intramuscular epinephrine, D, intramuscular glucagon. Very good. Intramuscular epinephrine. Remember, epi is always first line. You only give glucagon if they failed epinephrine first. All right, question 9. 2 weeks ago, a 16-year-old boy comes to his physician, a pediatrician, with cough, sore throat, and runny nose on physical examination. He has a fever of 101.1, mild pharyngeal erythema, and a small lymph nodes bilaterally on his neck. His physician prescribes amoxicillin for 2 weeks. After 7 days, the patient develops a morbilliform rash. What should be done next? A, reassurance. B, tell him he is allergic to amoxicillin and to avoid it in the future. C, tell him he is allergic to all penicillin family drugs and to avoid them in the future. D, tell him he is allergic to penicillins and to also avoid cephalosporins due to cross-reactivity. All right, very good, very good. So this case of amoxicillin is probably due to a virus, probably EBV, and so it has nothing to do with a true drug allergy based on the timeline. So just reassurance. All right, a 2-year-old boy presents with history of recurrent abdominal pain, vomiting, flushing, and generalized red-brownish macules. He also has had several hospitalizations for anaphylaxis. Which of the following tests would most likely yield the diagnosis? Appropriate skin testing, tryptase level, C1 esterase function, or IgE level? Very good. The answer is B, tryptase. He has all the signs of mastocytosis, so tryptase level would be a good lab to get for the diagnosis. All right. A 5-year-old boy with spina bifida has had multiple surgical procedures on his urinary tract and subsequently developed a severe latex allergy. What is the most likely food that he may be allergic to due to cross-reactivity with latex? Is it A, peaches? Is it B, pears? Is it C, potatoes? Or is it D, carrots? Very good, potato. I already didn't trick you guys with the 3 P's. Very good. So potatoes is the one. Okay. All right, next question. A 4-month-old baby girl is seen by you for the first time. On exam, you notice that the umbilical cord is still attached. The baby has severe gingivitis and several abscesses on the gluteal area. What test would most likely yield the diagnosis? Is it the dihydrorodamine test? Is it the nitroblue tetrazolium test? Is it C, flow cytometry to CD40? Or is it D, flow cytometry to CD18? Okay, all right. All right, we're all kind of all over the place, but all right. So let's go back and let's see all right. So this is a 4-month-old baby, okay? The umbilical cord is still attached, has very bad gingivitis and abscesses. So, what causes delayed separation of the umbilical cord, all right? And also gingivitis, leukocyte adhesion defect. So what are the 2 types of leukocyte adhesion defect? Well, type 1 is due to a CD18 defect, and type 2 is due to a fucosylation defect. So the answer is D, flow cytometry for CD18 is the correct answer. Now, A, the dihydrorodamine test is used to diagnose chronic granulomatous disease. B is also used to diagnose chronic granulomatous disease, okay? And C, flow cytometry for CD40, is used to diagnose the autosomal recessive form of hyper-IgM syndrome. So The correct answer is D, CD18 for leukocyte adhesion defect. All right. 18-month-old boy is diagnosed with severe Epstein-Barr virus, hepatitis, 4 months ago. He returns 4 months later with fever, diffuse lymphadenopathy, weight loss, fatigue, and malaise. What is the most likely diagnosis? Is it A, ataxia-telangiectasia? Is it B, X-linked lymphoproliferative syndrome? Is it C, Wiskott-Aldrich syndrome? Or is it, D, autoimmune lymphoproliferative syndrome? Okay, so we're kind of split on B and D, because I admit they do kind of sound the same. So X-linked lymphoproliferative syndrome is also known as Duncan syndrome, and that's when kids can get fulminant hepatitis, as in this case, especially with EBV, and unfortunately they progress to get lymphoma, so the answer is B. Autoimmune lymphoproliferative syndrome causes large lymphadenopathy all over, but they don't get really lymphoma, and they aren't susceptible to EBV infection. So the correct answer is B. Right. Next question. A 15-month-old boy with a history of eczema, thrombocytopenia, and recurrent infections is seen by you for his routine well child care. What vaccinations would be the most appropriate at this time? Is it the MMR, varicella, live intranasal influenza, DTaP, or OPV? Very good. So almost everybody got it right. DTaP. All the other ones are live vaccines, and you don't want to give it in someone who has a primary immunodeficiency. Okay. And that. All right. Next question. A 13-year-old boy presents with urinary retention. He has a history of recurrent skin and organ abscesses that grow out for Burkholderia species. Which of the following tests would most likely yield the diagnosis? Is it A, flow cytometry for CD18, B, dihydrorhodamine test, C, peripheral smear showing giant granules, or D, genetic analysis showing STAT3 mutation? Okay, so what do you guys think this patient has? Say it louder. CGD, right. So chronic granulomatous disease. Remember, the granulomas can form. They can cause obstruction, and therefore he has a urinary retention. He's growing out for a very unusual organism called Burkholderia. Okay, so the diagnosis is CGD. And unfortunately, the boards will sometimes ask you a step further, not just get the diagnosis, but how to work up the patient. So how do you work up for a chronic granulomatous disease? Well, A is flow cytometry, CD18 is for leukocyte adhesion defect, so that's not correct. B, the dihydrorhodamine test, that is the correct answer for chronic granulomatous disease, so B is the correct answer. C, peripheral smear showing giant granules would be seen in Shinya Higashi, okay? And then D, genetic analysis showing STAT3 mutation would be seen in Job syndrome or hyper IgE syndrome. So the correct answer is B. Okay. All right. Next question. A 10-month-old infant is seen by you for evaluation of neutropenia. Her absolute neutrophil count is 400. You check her absolute neutrophil count 3 weeks later, and it rises to 2,000. She has had a history of Pseudomonas sepsis. At the time of her infection, her absolute neutrophil count was documented at 400. So what is the most likely diagnosis? Is it Kostman syndrome? Is it cyclic neutropenia? Is it severe chronic neutropenia? Or is it HIV? Very good. Almost everybody got this right. The cyclic neutropenia, because the neutrophil level goes up and down, and when it's on its nadir, that's when she gets the opportunistic infection. Okay. 16-year-old girl presents with hives for the past 4 months. She complains of joint pain and general malaise that are not associated with heat or cold exposure. On physical exam, there are erythematous wheals on the extremities and abdomen with areas of hyperpigmentation and ecchymoses. What is the most likely diagnosis? Is it chronic idiopathic urticaria? Is it hereditary angioedema urticaria? Is it urticarial vasculitis? Or is it familial cold urticaria? Okay, very good. Most of you got this right. Remember the red flags for urticarial vasculitis? If they leave residual marks like ecchymosis, she has other systemic symptoms. So it's urticarial vasculitis is the correct answer. Okay. 18, a 14-year-old boy with asthma reports having cough 3 days per week, for which he uses his albuterol with relief. He has 3 nighttime awakenings per month because of difficulty breathing. He's currently on a low-dose inhaled corticosteroid and reports adherence with his medication, which is very important. And what is the most appropriate next step for him? So is it A, recommend continuing on the low-dose inhaled corticosteroid? Is it B, discontinue the low-dose inhaled corticosteroid and use albuterol only as needed? C, change to a medium-dose inhaled corticosteroid? Or D, add a leukotriene receptor antagonist and continue the low-dose inhaled corticosteroid as well? Very good. Most of you got it right. Based on the NEPP guidelines, this child has persistent asthma. It has more than 2 daytime symptoms per week, has more than 2 nighttime symptoms per month, is using his albuterol frequently, so he needs step-up therapy. The preferred step-up therapy in this age group is to change from low-dose to medium-dose inhaled corticosteroid, okay? An alternative would be to add the leukotriene receptor antagonist, but that's not preferred. It's the alternative, okay? All right. 4-year-old developmentally delayed girl with silvery hair and hypopigmentation of the skin presents with frequent respiratory tract infections. What findings on a routine blood smear would be consistent with the diagnosis? Is it A, small platelets? Is it B, giant granules? Is it C, absence of color change of nitroblue tetrazolium dye? Or is it D, pronounced leukocytosis? Okay. All right, very good. Giant granules is the correct answer. This patient has Shide Higashi with the oculocutaneous albinism and recurrent infections, and looking on a peripheral smear for giant granules is the correct answer. All right, very last question. A newborn comes to your office for a well baby visit. The parents are concerned because there is a strong family history of atopic disease. They would like to know how they can prevent the development of allergies in the newborn. According to the 2008 AAP guidelines, which of the following should you recommend? All right, is it A, the parents should delay the introduction of highly allergenic foods until after 12 months of age? Is it B, the parents should exclusively breastfeed the infant until at least 4 months of age? Is it C, the infant should be fed a soy-based infant formula to decrease the risk of cow milk protein allergy? Or is it D, whether the infant develops atopic disease depends on what the mother ate during her pregnancy, so it's too late? Okay, most of you have got this right. Now, this wasn't covered, all right, because this came out pretty recently in 2008, but it may be, almost fair game. So I just wanted to, let you know about the new recommendations from the AAP, okay? They've sort of changed their tone, delayed introduction of solid foods past, later on is no longer recommended because there's really no evidence to support it. Okay, the thing that's tried and true is breastfeeding is best. You want to recommend that the parents breastfeed for at least 4 months. Okay, and there's no evidence that any soy-based infant formula prevents any allergies, and there's no evidence that any maternal dietary restriction during pregnancy prevents atopic disease in infants. All right, with that, I think I'm out of time. Thank you guys. Good luck on your test, and if you guys have any questions, I'll be right here. All right.